Hello, everyone. This is Dr. Vishal Gewali from Queen's University, Kingston, Canada. And today I wanted to talk about the results of a phase 3 trial that was presented as a poster at ASCO. Although it was presented only as a poster, I think this is a very meaningful trial with very important conclusions and take-home messages for us all, especially in the global oncology community, but for anywhere in the world. I think this is very meaningful results. So the trial that I want to talk about was a late-breaking abstract from Tata Memorial Center, Mumbai. It was a phase 3 randomized trial evaluating the role of low-dose nivolumab to palliative chemotherapy in head and neck cancer. So as you know, in advanced head and neck cancer, cisplatin-based chemotherapy is the standard of care. The extreme trial showed that addition of cetuximab will improve overall survival. So that became the new age standard. But the keynote 048 showed that the addition of pembrolizumab also improved overall survival. So wherever access to these newer drugs is not a problem, the standard of care, I guess, is cisplatin-based chemotherapy plus pembrolizumab or cetuximab. However, as you know, pembrolizumab and cetuximab are quite expensive, and it's not available and accessible throughout the world. So Tata Center in Mumbai, they have previously shown that using metronomic chemotherapy, oral metronomic chemotherapy could provide very good results. Oral metronomic chemotherapy as an alternative to using the intravenous cisplatin chemo. It is oral and fewer side effects, and it is most importantly affordable. By triple oral metronomic chemotherapy, they mean erlotinib plus celecoxib plus methotrexate. So was the standard of care in the Indian subcontinent for advanced head and neck cancer. In this trial, what they did was they used, they randomized patients to receive this palliative chemotherapy with oral metronomic chemo versus palliative chemotherapy plus a very low dose of nivolumab. And by the low dose, we mean 20 milligrams flat. So this is a very low dose of nivolumab. And this was a very properly done trial with good power calculations, primary endpoint of overall survival. They had one interim analysis, and they also measured quality of life. So the design of the trial, based on what I could see, was very well done. And the results of the trial show that compared to the oral metronomic chemotherapy, the addition of this low dose nivolumab significantly improved the response rate from 49.3% to 65.2%. And most importantly, the primary endpoint of overall survival was improved. The median overall survival improved from 6.7 months to 10.1 months, which was significant with a hazard ratio of 0.5. The PFS was also improved. It was a secondary endpoint, but I was very happy to see that they measured quality of life as well. And the quality of life parameter in terms of physical functioning was significantly improved. And the other parameters, they did not change. But most importantly, I think the cost of this regimen is quite low if you compare to the cost of cetuximab or pembrolizumab or full dose nivolumab. So the reason I'm presenting this trial data is to say a couple of things. One, I was surprised why this was selected only as a poster. I thought this deserved to be an oral session because it has several consequences, important consequences and lessons for the world, which I'll be discussing now. And second, this also shows that the randomized trials that are coming from low and middle income countries are very valuable, and they are well done. And this was also proven in one of the JAMA oncology papers that I was a part of, led by Dr. Chris Booth, where we compared the randomized trials coming from high income countries with that of low and middle income countries. And high income countries trials, they are more often likely to use a surrogate endpoint and show minuscule benefit and claim statistical significance and use a medical writer to write the report. However, the trials coming from low and middle income countries, like the trial I just presented, they are using overall survival as the primary endpoint, and they are showing meaningful benefits in overall survival. And the other thing is these trials are so pragmatic. Because, as you know, the cost of immunotherapy is substantial, but we cannot also ignore the benefit of immunotherapy in several cancers. They have become the standard of care. So one way to reduce the cost of treatment is to reduce the dose of the treatment, not by affecting efficacy, but there are good reasons to believe that we are giving drugs to our patients at a higher dose for a longer time at a higher frequency for a larger number of people than what is actually needed. So, based on previous data, we knew that there is no exact dose response relationship for immunotherapies. And in fact, the peripheral receptor occupancy gets saturated at the dose of more than 0.3 milligram per kg. And this 20 milligrams of nivolumab is exactly that. It's for a 70 kilogram man, 20 milligrams means 0.3 milligram per kg. So by the addition of this low dose nivolumab, they showed that they can substantially improve overall survival. I think this is a game changer. And not only for low and middle income countries, even in high income countries, if you can gain overall survival benefit by using a low dose of immunotherapy, which is a pretty expensive agent, why would you want to go with the high dose? As you know, the tendency here is to go to higher and higher dose. Previously, even with pembrolizumab, we used to dose them on the basis of milligram per kg, but then they introduced a flat dose of 200 milligrams, which is higher than what people need in most cases. But I think this trial is very meaningful. I hope it gets published in a very good journal. I was really disappointed to see that it did not, it got accepted only as a poster at ASCO, because this has huge cost implications. And this is a game changer, especially for lower middle income countries. I think we should start to think about more of such pragmatic trials. It is a game changer for clinical practice, but also for the research enterprise. And I have been writing about this a lot, about what should be the clinical trial priorities for lower middle income countries. The trial priorities should not be, participating in another big multinational trial of a newer Me Too agent that will not be available, that will be costly, and that just is conducted to get the drug approved in high income countries. The priority should be to think about and run and participate in such pragmatic clinical trials addressing a local need. Head and neck cancer, oral cancer is a big problem in the Indian subcontinent, and trying to find the cost-effective measures to address those problems. So I really want to congratulate the authors and everyone who was a part of this trial. I hope this gets published in a very good journal.